Wow. After that introduction, I feel like I'm the Canadian men's hockey team. I gotta win the gold or there's no going home. So I'm really delighted to be here. I'm honored to be asked. Mark called me, I think the first time back in the fall, and asked me about this, and it turned out to be very complicated on my schedule. And so, I'd love to come to Vancouver because I love coming back here. As I'm Canadian, this still feels like home. And it turned out the dates weren't going to work. And so I wrote back to Mark about a week later, said, I'm sorry, I really can't make it after all. And he sent me a one-line email that said, call me, and it was this phone number. And I realized after that, I talked to him for 5 minutes, I was coming, I was making a huge donation, and I bought his daughter's used car. It was phenomenal. So I'd like to thank the Board of Trade for making this happen. Obviously, a lot of you are interested in healthcare, and I'm interested in healthcare, and I'm actually not quite a Vancouver boy, although I did live here for a large part of my adult life. I'm a Prince George boy, originally. Went to medical school at UBC, which it's been remarkable to watch transform itself under Gavin's leadership over the last 15 years into a really remarkable international powerhouse of biomedical research and care. So it's really fun and proud time for me to come back. And mostly I like to come back because I like Canadians. Canadians are nice people. I live with Americans all the time. And Canadians are nice people. That's the origin of the thing, why did the Canadian chicken cross the road to get to the middle? Canadians are conciliators. The American's the guy driving the truck running over the chicken and then eats it as roadkill because it's free. So I want to just try and focus a little bit today on some of the experiences we had unexpectedly in Boston last April, but most particularly I want to try to put them in context for you because you will never be asked to respond to a bombing at the marathon in Boston. In fact, I will never be asked to do that again. There's a uniqueness about every one of these events that makes it all the more compelling to take the lesson from that event and learn how to apply it. So I'm going to try and give you enough of the history and background, but mostly to give you the context of this event so that you could understand how you should, as members of this society in British Columbia, members of this society in Vancouver, business leaders, people who are influential in healthcare and government, how do you think about these things so that when this thing happens, it turns out the way it is supposed to turn out, or at least it turns out the best possible way. So I just want to say a little bit about my home institution. I'm just starting my 21st year there now as chair. It's a major Harvard teaching hospital. It was formed in 1914. We have 793 beds and 44 operating rooms. We discharge about 50,000 patients a year, and RED sees 60,000 visits a year, not nearly as many as the Vancouver hospital sees, and I remember fondly my days there. And then we have a tremendous number of people working there, lots of physicians and trainees, a $625 million research budget, which is part of our $2.4 billion operating budget. I wish it was a margin. And we're partnered with Massachusetts General Hospital in a large integrated delivery system that is very creatively called Partners. So I'm going to subtitle my talk today, You Have to Be Lucky to Be Good, but You Have to Be Good to Be Lucky. And I'm doing that partly because I just love sports analogies. This is a sports analogy. But also because this is always true in high performance events. And perhaps it has never been more true than it was on April 15th of 2013 when those bombs went off and in the time right after that. So I'm going to try to help you understand, not that we're so good and we did such a good job. We had good results. We had great results. But we didn't do everything so well, and we were lucky. And I want to try and share all of those perspectives with you so that you can think of how this fits in to your framework here. And I'm going to use the theme sort of preparedness, luck, and leadership moments. So let me go back in time to a simpler time. And there's something magical about people's ability to believe in the status quo, even if that status quo is threatened by obvious information. So if you go back to the United States, despite the World Trade Center truck bombing in 1993, and the Oklahoma City bombing in 1995, and the Atlanta Olympic bombing in 1996, all of which had casualties, some of which had horrific casualties, the Americans believed that they were fundamentally safe. And whatever was going to happen was not going to happen to them. And that was a big liability in terms of disaster preparedness. And I worry that that is a generalized sentiment, and that Canadians maybe feel the same way. And there's the legislature buildings, and you all remember last July, there was going to be a mimic, although I don't think it actually was a mimic, but a very similar event. 2 pressure cooker bombs filled with nails and screws and ball bearings, identical construction, made off the same internet sites that were exploded in Boston, were going to be set off on July 1st during Canada Day when those lawns are packed with people. That is Victoria, of all places. So the reason this is called terrorism is because it's sudden, unexpected, and terrifying, and it can happen anywhere, and it will happen anywhere. It just depends on the convoluted thoughts of the perpetrator. There's no convenience about this, and there's no mercy, and magical thinking doesn't get us away from it. So I want to now talk about the context of these events, and particularly the context about the Boston Marathon bombings and how we can think about these things. So all disasters, a disaster could be a hurricane, that's a disaster. But all disasters and all mass casualty events, mass casualty event is some kind of disaster that injures or kills a lot of people. They're all contextual. And these contexts affect how you prepare and plan for them and how you perform when they occur. And the context has to do with the event itself, but also your preparedness and your recovery after the event, which turns out probably to be equally important. So I want to talk about those contexts now, first with the event context. So I'm going to tell you a little bit about the Boston Marathon. I know at least one of you here has run the Boston Marathon. How many people have run the Boston Marathon? Just the one. How many of you have been at the Boston Marathon? Now we're up to 3, 4. How many of you have heard of Boston? Many more. I won't even mention that whole hockey thing. I'm sorry. And by the way, in answer to the first question you may ask in the question period, I did cheer for the Canadian men and the Canadian women in every single game, including when they played the Americans. Because, you know, there's sports, and then there's hockey. Americans don't get that. Anyway, so the Boston Marathon is run in April. It's on the 3rd Monday. It's a created holiday called Patriots' Day, apparently not after the New England Patriots, but something to do with a war a couple of hundred years ago. So there's a holiday, and it's just a state holiday. It's kind of a made-up holiday, and that's the day the Boston Marathon runs. It's a Monday. And it's run continuously since 1897, which makes it the longest continuous road race of its type. And it's one of what are considered to be 6 of the great world marathons. Now, of course, I heard that from people involved in the Boston Marathon. So they may consider it one of the 6 great world marathons. I don't know if it really is, but they think it is. It's amateurs and professionals. In 2013, we had about 27,000 runners, and we think 500,000 spectators along the course. Next year, there are going to be 36,000 runners in that race because they're going to allow everyone who didn't finish last year to automatically get to run this year. So they increased the number of legitimate runners. And they think 1 million people are going to line the course, many of them in defiance of this act from last year. People want to go out and prove that they'll come out. So here's a few pictures. You can see in that top left picture the enormous number of people running this race. This is Hopkinton, Mass, where it starts. And it goes from Hopkinton through 8 different towns and cities, including Wellesley, the little town I live in, and ends up in Boston at the finish line in the bottom left, 26.2 miles away. And it's an A to B marathon. So most marathons are not A to B marathons. Most marathons involve looping. And so the Boston Athletic Association that runs the marathon is very proud of the fact that they're emulating the original marathon theme, which is you run from somewhere to somewhere. No looping around. From my perspective as somebody who thinks about disaster preparedness, I like it because it strings out the people. The fewer people concentrated in any one area, the easier it is to protect and save them. So I like this linear marathon route much better than the loops and coils routes. So now we go to April 15th, 2013. They start the marathon, they start it in waves. So the first people off are the mobility impaired, the wheelchair runners, then the elites go off, then the registered runners, and then there's the charity runners and what we call the back of the pack. And the back of the pack are mostly bandit runners who didn't really qualify for the marathon. There are thousands of them. And they just run. They run pretty slowly. Some of them walk. And they just cover the course, and then they're doing the Boston Marathon. And along the lines, along these towns and cities, the entire distance are these hundreds of thousands of people with little kids handing Gatorade and doing things to help the runners, cheering on people they don't know. It's a really festive event. So this is mile 14 to 15. I just had to show this because this is my hometown, and that's the elites running through in Wellesley. And then they finish the race early. They finish about 10:45, and the whole first cycle of the race, the sort of serious competitive part of the race, is over just after noon, typically. And this year, it finished at 12:10. Show these pictures to remind you that this is not a sporting event like a bunch of people going to a hockey game or a football game. This is social. These are families. These are people going to the sidelines. They've got food and water. They stay there all day. They cheer for their coworkers. Then they cheer for somebody. Oh, I didn't know Susan was running. And they cheer for her as she goes by. And then Uncle George comes by. It's a family event. So it's packed. The sidelines are packed with people from newborn practically, 6 months old, all the way up to 80 or 90, all there to cheer on at least a few personal people they know, but they just cheer everybody. It's just a total feel-good event. So now let's talk about the preparedness context, because this is where it really starts to get critical. So we consider this event, and have always considered this event, a planned disaster. We know on marathon day that there are going to be many people who need immediate medical attention. The runners get hyponatremia. Their blood sodium gets low and they get delirious when they run because they're replacing water and losing salt. So their sodium gets lower and lower as they run. It's a big issue in long distance runners. They get dehydrated. If it's hot, which it is about every 4th year, they get heat stroke or hyperthermic, and they get funny from that. And they fall down and they injure themselves, and some of them wear out their joints and break their joints and get stress fractures. All these things happen. And it also happens to all these people along the sidelines. So we have this very sophisticated medical capability through the entire length of the course, but in particular at the finish line. And I'll show you that in a minute. The hospitals are all geared up for volume on Marathon Monday. We all know we're going to get more patients than we typically get on Mondays. And any emergency physician anywhere in North America will tell you that Monday is always the busiest day in an emergency department. So we have extra staff on because we know on this Marathon Monday, we're going to get all the usual stuff plus these marathon people. So our preparedness was long and deep. We had this long history of getting ready for this event, but our preparedness changed tone completely as a city because of 2 critical events. One that really changed our tone as a city, and the other that changed our tone in the hospital. And I want to tell you about those 2 events. So the first one is pretty obvious. It was 9/11. And I said earlier that America had this wonderful, reassuring sense of naivete before 9/11, and that was replaced with a real sobriety. It was really 9/11 that made the cities and towns and jurisdictions, the states, the federal agencies get serious about disaster preparedness and mass casualty response. Before that, it was almost like, oh yeah, we're supposed to have a disaster plan. Oh, we were supposed to do 2 drills last year. Did we do 2 drills? Well, we did 1 drill, and that's how it was. It was more to check the boxes and make sure you were meeting the requirements. After 9/11, people really realized they had to be ready, not just to think about it, not just check the boxes. So the entire country responded to that. In Boston, I talk specifically about Boston, we had always had citywide drills, but we really stepped these up. In our hospital alone, between 2006 and 2012, we did 623 separate tests and drills. So we had an activation or an actual event that invoked our disaster plan pretty well monthly in those 6 years. But in the city of Boston, in addition to these mass casualty drills I have at the top there, active college shooter, which unfortunately is a real consideration in the United States, more than probably it should be. But we did two particular mass casualty citywide drills that were interesting. One was Operation Prometheus in 2002, which was an explosion of a dirty bomb. And you know a dirty bomb is a bomb that is explosive, so it does all the injury that an explosion does, but it also has nuclear material in it so that you have radiation and nuclear contamination of everybody in a zone around it, including the people who are trying to rescue the people who are contaminated by the bomb. So we did a big drill on that. But in 2010, perhaps presciently, we did a drill called Operation Falcon. And Operation Falcon was a mass casualty bombing at a cluster event in the city of Boston. So if we had in fact designed a drill after the marathon bombing to test our capability, that's the drill we would have designed. The other event was Aurora, Colorado. So you remember on July 20th, 2012, James Holmes entered the Century Theater at midnight and opened fire with a huge armamentarium. There were 70 casualties, 12 of whom died, and 58 were injured. And that's particularly important because of a personal connection, which I'll tell you about in a minute, but it's also important because of one police officer's leadership moment. And I want you to listen to this broadcast. This is police radio.
Metro 10, Lincoln 25. Do I have permission to start taking some of these victims via car? I got a whole bunch of people shot out here, no rescue. Yes, load them up, get them in cars, and get them out of here.
So let me let you listen to that again now with the script of it, the transcript down below. Or not.
Metro 10, Lincoln 25. Do I have permission to start taking some of these victims via car? I got a whole bunch of people shot out here, no rescue. Yes, load them up, get them in cars, and get them out of here.
So an amazing little few seconds, because police have no responsibility for transport, none. Police secure the area, make sure it's safe for the EMTs to get in, make sure it's safe for the fire trucks to get in. No transport requirement. They rarely drill it. Some police jurisdictions drill it, most don't. They just don't do it. They don't even think about it. This police officer says, I'm standing here, there are casualties all over. These people were flooding out of the theater. I got casualties all over. There's not a single ambulance here. That's what he meant when he said rescue. Can I just load these people in police cars and take them away? And they did that. And that had two amazing effects. The first is they saved a lot of people they wouldn't have saved. But also, it resulted in 23 critically injured victims arriving at the University of Colorado Health Sciences Center, which is in Aurora, Colorado, not far from the Century Theater complex, in 1 hour. So from the time the first patient hit the door to the time to 60 minutes later, they had 23 seriously injured casualties in 1 hour. And so Kendall Ho, who's speaking to you later, as an emergency physician, knows that that's a preposterous number to try to deal with. And any emergency physician would know that, but I'll just tell you, it is a preposterous number to try to deal with. So I have two moments that involve me sitting in a chair that have to do with the Boston Marathon. And my wife says that these two big moments have to be sitting in a chair because I sit in a chair too much. And that may be true, but this was one of them. It was a Sunday morning. It was in late September, early October. I'm sitting there drinking my morning coffee, reading the Boston Globe newspaper on my computer, and a little window pops up, says, you got an email. And I look, oh, it's from Richard Zane. So I know Richard Zane really well because he's the professor and chair of emergency medicine at the University of Colorado Health Sciences Center. But before that, he was my vice chair at the Brigham and Harvard. So he had left me to go to Colorado and in fact relocated his family less than 48 hours before James Holmes walked into that theater. So he sent me an email and the tagline, the subject line was, take a look at this. And what was in there was the University of Colorado Health Sciences timeline. And they'd constructed a timeline of the arrival of these patients. It was just a bar going across the slide. It was a PowerPoint slide. It had, this one, and it said what they were. 23-year-old woman, gunshot wound to the leg. 24-year-old man, gunshot wound to the chest. And it just went across like this, and they were really bad injuries. And I remember looking at that and thinking, oh my God, that's a lot of people to arrive in such a short time. They were completely unprepared. It was the middle of the night. That's a lot of people to try to care for. And then I had this moment where I thought, could we do that? Have we ever thought about that? So I thought back on the drills we had done and what have we actually gotten ready for? And we had done citywide drills, but we have 5 level 1 trauma centers in Boston. We do a citywide drill We're not expecting 23 patients. And I actually went back through, I thought our number was 12, that we had drilled to 12 in 1 hour. But when I went back through and looked at the actual drills and the logs of the drills, we'd actually drilled up to 14. The difference between 14 and 23 is huge. 14 would be absolutely stretching your resources to the absolute limit. Then think of adding, again, 2/3 of that number on top of that. So we had never done that, and we were just on the verge of presenting our annual preparedness report to our hospital board. And it was a typical annual report to the board. It was full of self-aggrandizing fluff, and those of you who make presentations to boards know that that's what they are. And we've done all these drills, we've done all this stuff, we're so good, we're prepared, we're integrated with state agencies, we've got MEMA, the Massachusetts Emergency Medicine Response Group, we're working with us, everything's all, it was all good. And I looked at that and we just tore it up, started over, and asked the question, are we ready? Could we do 23 in 1 hour? And the answer was, we weren't. And we started then getting ready, deploying more kits, deploying more equipment, supplies, thinking about forming more trauma teams within our unit. We don't need 7 or 8 trauma teams, we need 15 of them to get this many patients through. And started retraining all of our senior personnel so they could fill the critical leadership roles if this happened. We started that in December, and we weren't anywhere near finished it in April, but we were better than we had been. So now let me tell you about the actual event itself. So we call it a planned disaster, as I said. This is the finish line. That large green grassy area in the middle is Copley Square. The little building, you can see the very corner of the roof in the front, in the foreground. That's the Westin Fairmont right there. The Fairmont Copley Plaza. That old building across the other side is the Boston Public Library. And the finish line's just around the corner there on Boylston Street. So the runners would enter off the left side of the frame and come down Boylston Street and cross that finish line. And after they cross that finish line, Boylston Street continues in what we call support. And support is a whole bunch of little booths giving out ibuprofen, Band-Aids, water, just stuff to help people recover right after they cross the finish line. Many of them are surrounded by their family and friends. They walk into that area, drink some water, sit down and rest, take some ibuprofen and so on. And then there's Medical A, which is this very sophisticated hospital, essentially field hospital that is set up there every year. And I'll show you more about that in a minute. So just to put that contextually, you can see Boylston Street running along diagonally from about 9 o'clock up to about 1 o'clock. So there's where Medical A sits on Copley Square. There's the support area. There's the finish line. And I just want to draw your attention to one more thing, which is this street right here, which is called Ring Road, which to the north of it abuts Boylston Street, which is the finish line of the marathon, and to the south runs into Huntington Avenue, which is a major 2 to 3 lanes each way divided road running right through as an artery through Boston. So there's a look at Medical A. If you look at the bottom right, everybody's got all the beds ready, got all the blankets, they're just standing around waiting. And if you look at the bottom left, that's what starts to happen around 12:30 as the runners cross the finish line and need care. So it gets to be very busy in there. But in addition to this very sophisticated medical tent with doctors, nurses, EMTs, we have dozens of ambulances lined up, and they're organized all like a Le Mans start, ready to go. So when you get to Marathon Day on April 15th, 2013, these are a lot of images people have seen before. The first explosion, happens at 2:49, and the second explosion is 13 seconds later, about 150 to 200 yards up the street. And I'm going to show you a short video clip here, and I want you to note a few things. The first is the suddenness of it. It goes from ordinary to extraordinary instantly. It's just so sudden. The second is the second bomb is almost irrelevant to the person who's videoing this, who's completely taken by surprise and swings the camera down the street. When you hear the second bomb 13 seconds in, you see a little cloud of smoke rising in the distance, and then he's right back onto the scene in front of him because the scene in front of him is so chaotic. And I want you to get just a little feel for that chaos, because that's what these things are like, and that's why they're called terrorism.
Well, gonna be people hurt out there.
Amazingly chaotic. People trying to get through the barricades that were designed to keep the spectators from merging with the racers. The rescuers could not get back through those barricades to get at the victims. Nobody knew what was happening. Nobody even thought, you talk to people who responded on the scene there, nobody even thought there might be another bomb, even though 2 had already gone off. Even when the second one went off, you saw nobody stopped running in to help. And you also noticed that those same areas that we set up to provide safety, these barriers, are dangerous once something starts to happen. And they really delayed people. You saw people trying to clamber over, really delayed people getting to it. And you got a sense of the chaos of that. It was almost mayhem. And that entire video that I showed you from beginning to end was about 1 minute and 11 seconds. So imagine playing that out in real time and having it go on for 15, 20 minutes, how emotionally exhausting that is for people. So the finish line you see on the aerial there, those are the 2 explosions. And to compare those to that little map I showed you earlier, there's the finish line. You can see Copley Square with medical A and support. There's Ring Road, bomb number 1, bomb number 2. So that's the setting. So how was Boston laid out to respond to this? We have 5 level 1 adult trauma centers and 3 level 1 pediatric trauma centers in the city of Boston. The city of Boston, given its geography and population, should have 1 of each, maybe 2. We criticize ourselves for our inability to be more efficient in the healthcare system. Why do we need so many trauma centers? So if you go to the Longwood Medical Area, Brigham and Women's Hospital, we share a campus with Harvard Medical School in the Longwood Medical Area, and right beside us is Beth Israel Deaconess Medical Center, another level 1 trauma center, so that's 2 almost side by side, and then Children's Hospital of Boston, which is a level 1 pediatric trauma center. You go up to Massachusetts General Hospital and the MGH Hospital for Children, adult and pediatric level 1 trauma centers, Tufts Hospital, Tufts University Medical Center, and their hospital, a floating hospital for children, adult and pediatric level 1 trauma centers, and then Boston Medical Center is another one down below, an adult level 1 trauma center. There's bomb 1, there's bomb 2. If you tried to figure out how to plant those bombs in a way that you could disperse rapidly equally to all trauma centers in Boston, that's where you would put them, right there. And on there, I've now got Ring Road marked for you, that little blue line under bomb number 2. And I just wanted to draw your attention to Huntington Avenue, which is this major artery right at the bottom of Ring Road that leads down to the Longwood Medical Area, up in toward Mass General Hospital and Tufts, and you just take a simple turn on Massachusetts Avenue, and you're right down to Boston Medical Center. It is an ideal evacuation route, and if you look at the positions of the bomb, Ring Road and Huntington Avenue, it was a very desirable setup for evacuation. So within seconds, people are responding. You saw that. Those are 2 of our residents in the bottom left corner who are working in Medical A, helping move casualties out. And we had a huge number of ambulances lined up. So here's another police officer's great leadership moment. And let me just play you this clip, and I've got the transcript there. You'll hear some radio chaos, and then you'll hear this very, very clear request that comes almost immediately.
Units, stay off the air. Units, stay off the air. Just make your way over there. All units, stay off the air and make your way over there. I only want to hear from the 984. I only want to hear from that supervisor.
Okay, Delta 984, here's what I need. I want Ring Road cleared so I can get ambulances out, okay?
Which is Delta 30?
Delta 984, give me a clear to what I need.
Cross.
Now that's leadership. We had never drilled clearing Ring Road. We didn't ask the police to clear Ring Road. They'd never thought about it. She looked at the ambulances, and you see them all lined up there. They were all over the place. Boylston bombs, Huntington's a big route, got to use Ring Road. And you heard her say, not only say it the first time, I want Ring Road cleared. Then Delta 30 jumps in and she says, no, give me clearance for what I need now, immediately. And Ring Road was cleared and the ambulances started running. And as a result, 118 patients got transported in 60 minutes. Now again, if you're not in emergency health services, it's hard to understand what that number means. But let me just tell you, if you're thinking about your investment portfolios, it's like a 92% annual return. It's a mind-boggling number to think of transporting 118 blast victims out of a blast site in 1 hour. Unheard of. And the reason that we have to think of this a little bit further is because if you think about what happens first at a disaster, we don't have these field tents and ambulances set up when these kind of things happen. They just happen. So somebody sets a bomb off, at a mass gathering. Let's say when all those people were on Robson Street watching that Stanley Cup final and a bomb goes off. Man, you can't even get near those people. You've got to scramble EMS from far away, get them in there. The fire department's got to go in. The police have got to clear roads. People are unsafe. They're running around. It's chaotic. You've got to get in there, set up a field tent, start getting victims, bring them over, evaluate them, triage them. Who goes to the hospital? Who stays here? Which hospital? How fast? You have to do all that before you even start evacuating. And that's why, although all the casualties are created in an instant, their arrival at hospital is nicely staggered. In this event, like in Aurora, there was no gap. Aurora, because the police transported them. Boston, because they were all ready to go, and that officer cleared Ring Road. So we started getting these casualties in unprecedented numbers. So from our hospital context, this was a holiday. Everybody else had the day off. We were overstaffed. They exploded this bomb at change of shift. We had our entire evening shift had arrived and none of our day shift had left. We were double staffed when that first bomb exploded. We had 44 operating rooms, but it was a holiday. Not everybody wants to have surgery on a holiday Monday. So our second and third OR slates were light. It made it very easy to create ORs. We were able to create them very quickly. Our ED was busy, but we've drilled emptying our ED so many times that that's not that challenging. And as this all starts to play out, I'm sitting in my office about half a block away from where the ED is physically located, doing my budget. Right? Imagine, you want to talk about sitting in a chair doing something that defines a mundane moment in your life. Unfortunately, a lot of those moments in my life that I'll never get back again. So I'm sitting, looking at my budget, and I'm with my administrator, and our phones ring at the exact same moment. So I pull my phone out of my pocket, and I look at it, and it's the hospital internal ring down number. It could be anybody calling from anywhere inside the hospital, or it could be coming out of the hospital switchboard. She pulls her phone out at the same time, and I said, Christine, who's calling you? And she said, I don't know, it's internal. So at that moment, I knew something happened. Why would we both be getting called at exactly the same instant? So I'm looking at my phone, just ready to answer it, and a blue banner drops down the top from USA Today, bomb explodes near Boston Marathon finish line. Before I answered my mobile phone, I knew I had to go to the ED because of USA Today. Now in the ED, you'll see, we didn't hear about it right away. We only heard about it when they were able to do a scene assessment, which was a few minutes later. But by that time, it was out on the feeds. So here's the timeline inside our ED, and I didn't do a patient-by-patient timeline. I just wanted to pick a few key elements. So there's the explosions at the left-hand side, 2:49 p.m., 14:49. Our ED was full with 66 patients. By 15:08, it was completely empty. We had 7 trauma teams ready to go in that 20-minute gap. Now, I mentioned earlier, all our trauma surgeons were in the hospital. So they were all around. It was a Monday afternoon. They were working. Got them all together, assembled trauma teams. Each trauma team was exactly the same kind of trauma team we use every day. Trauma surgeon, emergency physician, nurse, and a tech. We had them all over the place. So our first patient arrives at 15:08. And Code Amber Phase 1 is the alert we get from the field. It just says something's going on. We don't know anything about it yet. That's just all Code Amber Phase 1 does in our hospital is nobody can go home. We don't know anything yet. Nobody can go home, though. When we saw the first 2 casualties come through at 3:08, we upped it to Code Amber Phase 3, which is our largest scale disaster response because we saw the types of injuries on those first 2 patients. And we knew this was, whatever it was not going to be anything ordinary. So we went to Code Amber Phase 3 at 308, and I just want to point out one more thing on this timeline. If you look from 308 across to the middle to 408, 1608, just below the line in the center, that's the 60-minute mark after the arrival of our first patient. And in 60 minutes, we got 23 patients. We got exactly the same number Aurora got. Isn't that amazing? Not made up either. Actually happened. So we had 40 survivors altogether. 16 were admitted, 9 required surgery. All of those required multiple surgeries. Our community site, which is nearby, which we also operate, not a trauma center, got 14 patients, lower acuity. 5 were admitted, 4 required surgery. Not a single patient who arrived at a Boston hospital alive died. Any Boston hospital. Not one. So I want to try and put this together a little bit for you, but there's one more little piece to the picture, which is that right after these events, you have to start recovering. The first people you have to recover are your staff. We call those hot washes. You just get everybody in a room and let them talk. I was worried that there was radiation in the emergency department. I'm like, why were you worried about that? There was a guy there with a Geiger counter, and there was. We had people all over the place walking around with Geiger counters to see if these patients were contaminated, but we didn't communicate with our staff what they were doing, and that the answer was no. So every single staff, we had a pregnant nurse working. She was terrified that she was irradiating her fetus. So hot washes are a chance to get everything out right at the moment. It's from the military parlance of washing your weapon right after battle while the weapon is still hot. So we start all this stuff and we start all this outreach after action plans are developed from a series of debriefings. You start right away. But then there was disaster alert number 2, and you remember what happened next was that they identified the perpetrators in an unbelievably short time. And one of the keys to this, I was just found out last week actually, so this is hot off the press, is that they used the pedophilia and human trafficking experts from the FBI to look at the surveillance video and identify by their body language people who were likely perpetrating. And they narrowed down very rapidly from this huge thousands and thousands of frames to a very small number of people and started studying those people. And they identified these people correctly, allegedly, in 48 hours. Really incredible, if you think about it. So then, shelter in place. There's a big shootout in the middle of the night. One victim still at large. Shelter in place means don't move. This is rush hour Friday morning, April 19th, 2013. Those arteries are as clogged to a standstill as you can imagine, and there's not a single person out there. So from the hospital perspective, I went home the night before late, as I had all week, and I said to Barb, you know, my wife, I think all I need is one good night's sleep. I'm not going to go in early in the hospital tomorrow. I'm just going to go to sleep. I'll sleep. You know, they'll find the guys. At least our part's over. And at 3 o'clock in the morning, this shootout starts, and they order the shelter in place to go back in the hospital, and our whole senior leadership team had to come back in on Friday morning. And I think people felt like they had survived a title fight with a really good fighter, and they got to round 10. It was a 10-round fight, and they sat down, and they got their Gatorade, and they think, thank God I survived that. And then somebody rang the bell and said, okay, bing, round 11. And everybody had to get up and find that in themselves again to do this all over. But once the dust settled a little bit, we realized it was really just like a snowstorm without the snow. There was nobody really in danger here. Nobody was going to get hurt, or not likely anyway, and it would be small numbers. What happened was our staff couldn't get to and from the hospital. So we had to figure out how, it's just like a bad snowstorm. How do you deal with that? And that turned out to be pretty straightforward. So then they caught the guy. There's the heat image from the sky, from a helicopter of him lying in the boat. Amazingly, you see that little stepladder there. They had all these people, it was a town like Burnaby, they had all these people shut in their houses, and they were armed police. You must have seen them. They, you know, just these very, very well-equipped tactical police officers with helmets and boom microphones and night vision goggles, and they're going all through these regular neighborhoods. And they finally said, okay, we can't find them. It's okay to go out of your house. And one of the guys in this house looks out in his backyard and says, oh, good, because I've been trying to figure out what happened to my boat out there, because the tarp is torn and there's blood on it. I'm not kidding. So he goes out in his yard, and he climbs up, he puts a stepladder on the boat, he climbs up the stepladder. That's why the stepladder's there. And he looks in, and he sees the terrorist lying in the bottom of the boat who had been shot. So he was injured, wasn't, I guess, that feisty. Guy falls off the ladder in shock, runs inside, dials 911, and actually talked to the Somerville police officer who took that call, who said it was like the 250th call they had in about an hour after they released the lockdown of people saying, the terrorist's in my backyard. But he was in this backyard, so they flew over, got him, and arrested him, and you'll learn more about what happens to him later when we all do. So I wanted to just close with a few lessons learned and how you could think about this. So the first is that preparedness response, disaster preparedness, whatever term you want to use, it's about structure, not about capability. You don't prepare for a hurricane. You don't prepare for a flood. What if you prepare for a flood and you're all prepared for a flood and you get a massive grid knockout instead, including your backup emergency power? Well, that's worse than a flood, but you're not ready for it because you were ready for a flood. So it's more about creating a structure that is so well tuned that it can respond to anything. That's the key to preparedness. And I would just ask you, a lot of you are involved in business and in healthcare, is your business ready? Do you have a plan? Do you have a supply chain plan? Do you have a safety plan for your employees? Who runs that? How important are they in your company? Is it run by some little, way off in the corner person who fills out forms? Or is this a central part of your business ethos? Because you need to protect your people. Nobody else can. In the first minutes after this, nobody can protect your people, just your plan that you've developed. So are you ready? Next lesson is test and drill until you can't do it anymore. It's like a sport. The more you do it, the better you get at it. And if you don't test and drill, you can't perform. And if you do test and drill, then those virtuoso players that you have, they'll play. They'll rise to the occasion. They'll have their leadership moment and they'll perform at an incredibly high level, including solving problems on the fly that you did not anticipate because they're so ready, they're psychologically ready. So every disaster has something to teach. Learn from them and evolve. After a drill or an event, we have a tendency to sit back and say, wow, we did really well on that. People always do well on drills. They usually do well in events. So you feel really good about how your team did after all this preparation. You tested them and they responded. That's 10 minutes. After that, get critical. The only thing that really matters are the things that didn't work. What didn't work well? And I could give you 150 of those that we learned in the first 3 or 4 days after we started reviewing at the Brigham. And leadership has to lead. It's not enough just to say that this is going to happen and you're the leader and you're going to make it happen. You have to actually make it happen. It's not about budget and it's not about allowing employees a little time to do this. It's about a personal commitment from leadership to say, this is important, this is valuable to us and we're going to do it and we're going to be good at it. And we hope we're so good at it that if it ever happens, we'll perform well. But we know it's statistically not likely to happen, but we'll be ready. We'll be ready. And that matters personally to me. So from Boston perspective, we were ready for sure, but we were really lucky too. The elite runners were long gone, and with them, a lot of the people that would have been gathered around that finish line. It's really packed at noon. It's a lot lighter at 1:30. The Back Bay location I showed you, perfect. Get to all the trauma centers quickly. We already had a field medical system set up there and 50, 60 ambulances ready to roll. Sitting there all lined up, ready to go. It was light holiday traffic. Nobody in his right mind would drive his car in downtown Boston on Patriots Day Monday. The marathon, a Boston Red Sox game, nobody would drive. The hospitals were at change of shift. We had holiday OR. I mean, it just goes on and on. We were lucky that this played out the way it played out. So our goal, as we look back at our response to this, is to be critical and eliminate the luck. And I'll leave you all with that same challenge. Thank you very much.
I've used most of the time, but I indulge and do 2 questions.
I must confess I'm not sure what to say. There are many people in this audience who know that I've done a fair bit of moderating and never met a microphone I don't like. But that was absolutely astonishing. And we've actually used all the time, but if you'll indulge me, there are a couple of questions I think we should take advantage of you being here. And if everyone's okay, we're going to run over just a wee bit on this session, and I see a bunch of nodding heads. I have to ask a question. It showed up on the Pigeonhole technology, and I'm going to frame it slightly differently. But your profession is so disciplined in so many ways. And the men and women that you work with, whether they are nurses, the EMTs, the physicians themselves, whether in the trauma or the OR, you're so well conditioned to keep the emotion out of the moment. This is the extraordinary moment. How do you deal with that after the fact? How do you deal with your team and not just in the moment, but probably reality being what it is, after the fact, get people back to a mental state of good health, to return to the workplace as quickly and as effectively and deal with all of that? What can you tell us about that?
So that's a very complicated business. There's another whole talk around that I promise I will not inflict on you. That night about 7 o'clock, I called Rich Zane in Colorado. Because I knew by then everybody was in the OR, I was going to the OR, everybody was in the ICU who was going to the ICU. The ED was way over the top. We had crested, we knew we weren't getting any more, not any number we couldn't deal with. We never had fewer than 3 trauma teams completely ready to go without a patient, just waiting for a patient. We felt really good. I called Rich and I said, what do you wish you did differently in the first 72 hours after that? And he said, we did a huge amount of work for our staff. It's all built into our plan. And I actually interrupted him. And I said, yeah, we've got it built in our plan too. And he said, it was way too little. Whatever you think you should do, double it and then triple that, and it still won't be enough. So we actually set up individual debriefing sessions. We got residents with residents, nurses with nurses, residents and nurses who were working together with techs. They were in one room, 4 of them. They debriefed separately. We got all the people who were in one area, 40 of them. They debriefed separately. We got people with their friends, people with their family. We did all of that. But interestingly, we also had our employee health professionals call every single person on the telephone. And I know that happened because I got a call in private at home. I know you went through a lot on Monday. Just thought you might want to talk. If you want to talk, you want to talk. And we got a whole bunch more people out of that we had not identified in our sort of routine, pretty rigorous debriefings. So it still goes on. Rich told me in Colorado they had a huge relapse in a lot of their caregivers after the Newtown shootings in the school. A lot of people had flashbacks and sort of fell back. So it's a long recovery for some people and shorter for others, but you have to make that commitment to recovery for your staff the same way you make the commitment to preparedness.
Your question makes me think of others. I'm going to ask you, there's a technical one here that is, I think, more tactically focused on the response side of it, which is the prioritization. As you see this sea of distress coming into your environment, how do you determine, what does a triage look like? How do you determine when everyone seems to be in such critical shape? So
remember, triage is a concept that's created when there's a mismatch of resources for demand. So you don't need triage. Most emergency departments don't need triage 90% of the time. We eliminated triage in our emergency department because who needs to triage? If there's a bed, just take them in the bed and see them. Emergency departments like triage because it keeps people out and controls the flow. In a mass casualty event, though, the situation's completely different. You have an overwhelming number of casualties and a very limited number of resources, and there's no prioritization by women, children. This guy's 72, he doesn't have much life left. This boy's 12, let's take care of him. It's guided strictly by injuries and survivability, which we're good at predicting. So in those moments of field triage, you look at these people and you say, what category of triage are they? Evacuate immediately is one. Evacuate in the next hour. Stabilize here and evacuate in the next hour is another. Evacuate whenever. This person just has a bad ankle injury. They can wait 4 hours if they need to. And then there's what's called a black tag. A black tag is this patient's still alive, but they're not salvageable. So don't evacuate them at all. And that's the thing that field triage people struggle with. That call that this person's a black tag means they're still alive. You can often talk to them, but they're not going to survive. And you can't use the resources, even an ambulance, to transport them. So the field triage is a very different level than the hospital triage. In the hospital, you set up a secondary triage level, but we never were short of trauma teams. We always had these trauma teams set up, and the reason we did, that was one of the benefits of our Are We Ready discussion and preparation. We had many more trauma surgery kits and designed around setting up many more teams than we had in the past. So we never had a patient arrive who needed a trauma team who didn't have a trauma team. And then the patients who are less severe than that, they can go into a regular ED room, and we still have regular ED personnel to care for them too. So in the hospitals, it wasn't really, at least in the Brigham, and I think it's probably true for all of them, it wasn't really a triage issue. The triage issue arises in the field.
One of the most sobering presentations I ever received. I was privileged to spend some time in government, and leading up to the 2010 Olympic Games, I actually got a briefing from the Defense Department on the security rings around Vancouver 2010. And the preparation, to your point, was enormous. The what-ifs, the military people who were in the forests around Whistler, I mean, it was incredible planning that was in place, and I walked away from it a little unsettled because you realize how seriously it was taken. So on the one hand, it was comforting, and on the other hand, it was very unsettling. When we look back at what for us was a magnificent feel-good experience of the Vancouver 2010 Olympics, knowing what you know now, and you may be repeating some of what you've already said, so in which case just summarize it, but is there anything that, as we gather here to learn from you, is there anything that you could say or recommend or reflect upon that would help the emergency preparation side of our healthcare system for dealing with an event like that in the future?
I would, and I'll try and keep it short and simple, which you know by now is not my nature. Emergency services everywhere in North America are under-resourced. You have emergency departments, you've been in them. Even your elite emergency departments like the Vancouver Hospital, St. Paul's Hospital, these elite departments, they're under-resourced. They are jammed to the rafters with patients on stretchers waiting for inpatient beds they're not going to get for a day or 2 days. The whole system is under-resourced. You get by with that because the people inside that system, I know this sounds a bit preachy, but I'm a preachy kind of guy. You get by with that because the people inside that system work so hard. You have emergency physicians and nurses working in environments that no other doctor would work in. Imagine you're a surgeon, you walk in the OR, do heart surgery, you walk in, and there's 3 patients in there. And they say, well, sorry, the main OR table's in use, but you can operate over in the corner, and we got a part-time scrub nurse for you. They're not going to do that. Nobody does that anywhere in healthcare. We don't take patients and put 2 in a room when the rooms went for 1 up in the wards. It's 1. It's just 1. But in the ED, there's 7 patients where 2 patients should be. They're in the hallways. And emergency physicians all the time have to make those kind of triage decisions I talked about earlier, but at a lower scale. So if I had one message for you getting ready, had something happened, say at the Olympics, or will it happen at a future mass casualty event? Maybe it'll be the Vancouver, what's it called now, the Sun Run? Maybe it'll be the Sun Run. Maybe it'll be an event downtown. Maybe it'll be a sporting event. But if something happens, your emergency systems, both the pre-hospital part and the emergency departments in your hospitals, they have to be big enough and well-resourced enough to be able to have that elasticity. If you get an epidemic flu here, which is far more likely, 1,000 times more likely than any of these bombings, you get one epidemic flu season here, and your emergency system will be so broken, you won't even be able to figure out where to pick up the pieces. So I would encourage you, as an outsider now, but feeling that my heart is still here, if you have some emotional energy to spend it educating yourself about the capacity and capability of your emergency systems and how to make them bigger and better. Thank you.
So we have gone over. Thank you for that. Let me wrap this up as I can, and getting ready for just give a heads up that we're going to move to the next speaker. So Marshall will give you the cue here. When you started your remarks, you made comments about hockey and whatnot, and I was thinking of all kinds of witty and trite little things to say about hockey. It seems so trivial after what you shared with us today, so I can tell by the utter silence in the room that I'm not alone in the reflection that's taking place out here, and one part reflective, one part frankly inspired by what you've done. You know, we're awfully proud of our hockey teams, but I think it's fair to say that I'm not the only one awfully proud of you being a Canadian. So ladies and gentlemen, please join me in thanking our guests tonight. Thank you so much for that. And we've got a valuable parting gift from Purdy, so we'll get to that.
Thank you. Thank you.